Hi, this is Elliot Fishman, and welcome to part 4 of our talk on large adrenal masses, pearls and pitfalls. And I left off last time bringing up adrenal metastasis and common sources: lung, renal cell, melanoma, hepatoma, colon cancer. Those are the most common. Melanoma we see frequently. Now, one could argue in many ways a met is a met, but that's not always the case. Most renal cell metastases are from clear cell, which are typically vascular, and so renal cell metastatic to the adrenal is often bilateral, but be it bilateral or unilateral, they're very vascular. The only thing that looks like a renal cell typically is a pheochromocytoma. Melanoma, commonly bilateral, often with other sites of disease, but are often very large. Hepatoma, also unilateral or bilateral, but gives the largest adrenal metastasis I've seen. Sometimes when it's an initial presentation, you can't say, is it hepatoma metastatic to adrenal, or is it adrenal primary metastatic to liver? I guess the thing that helps is if you have a cirrhotic liver, then it's most likely going to be a hepatoma. And again, colon cancer in the scheme of things is uncommon, but it does occur. And in truth, any primary tumor can go to the adrenal gland. In this article by Yip and Jama, adrenal mets commonly occur: lung, kidney, breast, melanoma, and colon, but literally any site. Can be unilateral or bilateral. An adrenal metastasis resection usually is not done unless it's the only site of disease, which is unusual. Remember, I mentioned before about biopsies. Metastasis will often be biopsied if you're not certain if it's a met, and of course you want to make certain you're doing the right therapy. At times, PET can be done to look for mets to the adrenal, but PETs can be positive with benign lesions as well. Here's a patient with colon cancer. There's mets to the pancreas with mucinous calcification. Look at the large bilateral adrenal metastasis. Truthfully, I would not have picked colon cancer. I might have picked melanoma or renal cell if you only show me the appearance of the patient's adrenal masses, because they're both large, somewhat necrotic. And of course, you could have thought about a pancreatic mass. That would have been very atypical with the calcifications, maybe a mucinous cystic neoplasm, but then metastases are often exceedingly rare. So that's something you're just not going to see. And here it is on the volume rendered, showing you very nicely the areas of necrosis within the tumor. Another patient, non-contrast, where you see bilateral adrenal masses, could be adenomas, could be a number of things: bilateral pheos, bilateral mets. When you give contrast, look at the lesions on the right. Central necrosis. If I told you this was bilateral pheos, which occur 10% of the time involving both glands, you could say yes, it is. But when you look at this patient, of course, the patient's had a partial nephrectomy, and this is metastatic renal cell carcinoma. So metastatic disease, I mentioned before, from kidneys, particularly clear cell, are often very vascular. Another patient, large left adrenal mass, could be a primary tumor, could be metastasis. You can see there's some clips from a right nephrectomy, and the liver falls posteriorly. There's some vascularity in the lesion, and based on the history, this is metastatic disease, right? Could it be a primary ACC? The answer would be yes. You might go through some other differentials, but this is a good example where you would have had an old scan. This lesion appeared. There's prominent vascularity. It's solid. This is metastatic renal cell carcinoma. You don't need a biopsy. The patient will be treated with chemotherapy. The patient already was on some chemotherapy. Maybe you'll change the chemotherapy, but metastasis from the patient's renal cell. And here you can see on the late phase imaging, it washes out, it's low density. So, of course, the appearance of metastasis will depend whether you're scanning arterial phase, where the lesion will show its best vascularity, or on late phase imaging, where it will show relatively decreased vascularity, as was the case here. In patients with renal cell and hepatoma who undergo dedicated adrenal imaging, percentage enhancement washout can be similar to adenomas. And again, we say that because they're very vascular. We say the same thing with pheo, but typically it's not going to be a problem because you can look at the lab values and the lab values are normal. Also, pheos typically are homogeneous, but they can be centrally necrotic, so they can look like mets. There's no doubt, but lab values and clinical history will make your life a bit easier. Here's another patient, bilateral metastasis. Patient had renal cell carcinoma, right nephrectomy, 2 large masses, some vascularity, marked central necrosis, small left para-aortic nodes are present as well. But in the face of a right adrenalectomy, I don't think you're going to be chasing down a very long differential diagnosis list. And it's interesting as you go from arterial to venous, how much more the central necrosis within the tumors is shown. Just very, very nice example of bilateral metastasis from renal cell carcinoma with necrosis. Now, if you didn't have a right nephrectomy, it would be a much more difficult case. You could still think about metastasis. You could think about cystic pheos. We mentioned primary ACC. The frequency of bilateral masses is under 3%, truthfully probably under 1%. Now, sometimes I showed you the neovascularity. Sometimes mets can be very cystic. This was non-small cell lung cancer. Now, could you be confused with a cyst? Well, we had the adrenal looking good before, but more importantly, you see the rim enhancement. So it's not going to be a simple cyst. Could it be a cystic lesion that bled? Could it be a met that bled? Which is indeed something you need to think about, but it's kind of easy. Now, we mentioned before that besides renal cell, the mets that are very vascular are going to be hepatoma. Here's a patient, cirrhotic liver, known hepatoma with large bilateral adrenal masses, which are vascular. A very classic appearance in light of the history of metastatic hepatoma to the adrenal glands, very nicely shown. You see the vascularity in both adrenal glands. This could have been metastatic renal cell carcinoma. There are several possibilities. You also can see the very aggressive lesion by the patient's left acetabulum. Look at this large tumor with destruction of the acetabulum, the iliac bone, and the ischium. So a typical met from a hepatoma, which can be very large to bone, 3 to 5% of cases, as well as bilateral metastasis to the adrenal, which are again nicely shown on the cinematic rendering, as well as nicely showing you the large bony tumor in the patient's pelvis. Another example, large left adrenal mass, and this was the presentation, and you see a mass in the liver. That's that question I had before, adrenal to liver, liver to adrenal. But the patient's liver was cirrhotic, and that makes it a bit easier. This was metastasis, large cystic mass. I do wonder if this lesion could have bled perhaps at some point, but large mass, a hepatoma metastatic to the patient's left adrenal gland, very nicely shown. And you can see also there's metastasis in the region of the patient's right adrenal gland, and there's nodes present in the patient's portal caval space. A very, very nice example. And here it is as you go to later phase imaging. Now, melanoma is one of the things that commonly will metastasize to adrenal, but often you'll see other organs, be it lung, be it bowel, be it liver or spleen. They can be large. They can be nice and round, like in this case. Not very vascular. I mentioned they can be vascular sometimes, but typically they're not very vascular. They're solid. There's a little bit of vascularity in the lesion, but for the most part, these lesions are solid masses. So again, when I see bilateral, I think of renal when it's vascular. I think of hepatoma, hypovascular or hypervascular, and then I think about melanoma. And yes, of course, lung cancer can be bilateral. I showed you a colon cancer. Some of the GYN oncology tumors can be bilateral. So anything can be bilateral over time. But again, statistics tend to favor going after the tumors I mentioned. Another melanoma case, large bilateral lesions, somewhat cystic. Again, consistent with metastatic disease. As you go from arterial to venous, you also see, by the way, this mets to the spine. Could this be a myeloma with mets? That would be rare. Could it be a hepatoma with metastasis, renal cell with metastasis? This was melanoma. Okay, very nice example. Multiple bone lesions and mets. Now, another thing to think about, so we've talked about primary ACC, and then we talked about metastasis. The next thing I want to mention in malignancy is adrenal lymphoma. Most of the time when you see adrenal lymphoma, you see spleen involved, you see liver involved, you see bulky adenopathy, because lymphoma is a multi-organ disease. But you can have primary adrenal lymphoma, okay, typically non-Hodgkin's, and in those cases it's bilateral. The lesions are large. They maintain what looks like the adrenal shape, and they're homogeneous. Now, one of the reasons I'm showing you this, and I want to focus on the thought of this possibility, is remember we talk about no biopsies because of ACC. But the appearance of lymphoma, when it's bilateral especially, is very classic. And those are the ones you want to biopsy because then you can treat with chemotherapy. You would hate to do an adrenalectomy on a patient who ends up having lymphoma. When you talk about lymphoma, it can be primary or secondary. Again, secondary is easier to diagnose because in those cases you see liver and spleen and nodes or kidney involvement as well. They're usually non-Hodgkin's, and again, bilateral or unilateral. When it's bilateral, it's much easier to diagnose. When it's unilateral, it's a little bit more challenging. Now, again, primary adrenal lymphoma is rare. It's usually elderly patients, male predominance roughly 2-to-1. In patients with bilateral involvement, adrenal insufficiency may be the first presenting symptom. So again, you have to be aware, fever, weight loss, back pain, but adrenal insufficiency can be due to many things from hemorrhage to tumor infiltration. And again, in terms of appearances, this idea that it maintains the adrenal shape becomes very, very critical. And that's very, very important to us because that's how I'm able to make the diagnosis in most cases. It's usually relatively hypovascular, rarely has calcification. So again, the facts. Median age, 65. More common in men. Bilateral involvement, 73%. 50% actually develop symptoms of adrenal insufficiency. So all of that together can help you with the diagnosis. So CT appearance, if I have to describe it. Large masses, usually bilateral, exceeding 10 centimeters, with infiltration maintaining the adrenal shape because it infiltrates. So the triangular shape is still there. And again, other times it could be necrotic, there could be cystic components, it could be unilateral. And in those cases, differentiating it from adrenal cortical carcinoma or pheo or metastatic disease is indeed going to be very, very difficult. And I love this infiltration appearance. On CT, an adrenal lymphomatous mass can be homogeneous with washout features similar to other malignancies. Prior to treatment, calcification is rare, but the infiltration. So here's a big mass. This was a large left adrenal mass. We can go through the differential diagnosis. It's solid, but it's not very vascular. Could this be a primary ACC? The answer is yes. I would have to worry about malignancy. I don't see adenopathy. There's nothing really all that special compared to some of the primary ACCs I told you about. This patient was worked up and this lesion was resected and it was lymphoma. Very, very hard to make the call when it's unilateral. On the other hand, in this case, it's unilateral, but it's infiltrating. Remember, ACCs can be extensive and can infiltrate the kidney or the periodic region, but here it's infiltrating in a way that the vessel is preserved. Now, we always talk about lymphoma, the sandwich sign when you have mesenteric involvement. This is the same type of thing. Look how the tumor is infiltrating into the kidney. It's encasing the vessels. In this case, I would suggest primary lymphoma. And again, you biopsy this. That breaks the rule, but I'm so certain it's lymphoma that I'm happy to break the rule. Now, here's another case, bilateral adrenal masses that are large. And yes, you say this could be metastasis. Maybe it's melanoma. Maybe it's something else. But look how infiltrating these lesions are. You can see the adrenal shape. And so you think to yourself, this got to be lymphoma. I don't see any nodes infiltrating. Maybe on the left and the right, there's some areas of little necrosis, but bulky bilateral masses, no history of primary tumor, no history of anything else. I think the best thing you could think about is going to be lymphoma, and this was lymphoma, very nicely shown on the cinematic rendering as well, with the areas of necrosis more accentuated. Or this case, look how large the adrenals are. They're low density, homogeneous. Even on enhancement, the left enhances a bit more than right, but both of them are homogeneous, and if you think about it, they do tend to maintain that triangular shape. Bulky bilateral masses, 65-year-old male, you got to be thinking primary adrenal lymphoma and biopsy, and then treat this patient. Beautiful example, here it is on the coronal views. And as you go through the images, I have a number of images to show you. Look how the left and the right look triangular when you look at the coronal view. Here it is, the cinematic, showing you the enhancement is different between right and left. There's more enhancement on the left, maybe a bit more necrosis on the right. So they look different. So not every lesion, even the same patient, is going to look the same. But this is a really, really nice example of primary adrenal lymphoma. And here's an article we published a couple months back. It's well worth reading, by Taha Ahmed and our team, both pathology and radiology and surgery. So primary, we said a few things here. Primary adrenal lymphoma is a particularly rare subset of tumors. And we mentioned that cinematic rendering can be very helpful in diagnosing it and in staging it. We talked about how rare these tumors are, and you can read the article, but again, symptoms of weight loss, fever, abdominal pain. It kind of has the typical symptoms of malignancy, but also makes you really think about lymphoma. Given the infiltrative growth of these tumors, the adrenal shape is maintained. And again, to me, that's what it's allowed me to make the diagnosis correctly in essentially all the cases that are bilateral. Sometimes when it's unilateral, I could be really suggestive, but in the one case I showed you at the beginning of this talk, there's no way I could have said that was not an ACC, and so you did not want to biopsy this lesion. And then we talk about cinematic rendering also in this article, boosts real-time post-processing and windowing capabilities, allows better understanding of the patient's tumor, and perhaps can be helpful in making the correct diagnosis. And we did speak in the beginning of the series about how cinematic rendering can be valuable in benign and malignant tumors, but this article really looks very nicely at how it helped us reach the diagnosis of primary adrenal lymphoma. And again, we talk about the risk of biopsy, the fact you don't want to do it when you can think about ACC, but in lymphoma, you would hate to go in and remove the adrenal gland simply to find out you were dealing with lymphoma. It delays the onset of when you can give the patient chemotherapy because of the recovery time. And so when you're thinking about that, of course, you can also then perhaps get a PET scan if necessary. The PET might be helpful finding extra adrenal sites of disease, but also the PET should be very, very hot, though there hasn't been, to my knowledge, any real series in this area. And again, the cinematic rendering, nuanced characterization of adrenal masses. So I think we're doing a lot of work, other people are doing a lot of work in this area, and we'll see what else we can find out over time. Now, when we talk about bilateral adrenal masses, lymphoma is right up there. 10% of pheos are bilateral, but the most common tumor bilateral is going to be a pheochromocytoma. So let's do this. Let's stop with this slide and let's come back and finish up part 5. It's not very frequent that I do 5 parts of anything, but this will be part 5 of the adrenal, and we'll see you in a couple minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.